Welcome to our conference session, Understanding PNH. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, type your question in the text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Dr. Ilene Weitz, who is an assistant professor of clinical medicine at the Keck School of Medicine at the University of Southern California. Dr. Weitz is board certified in internal medicine and hematology. Dr. Weitz' research and clinical interests include disorders such as anemias, thrombocytopenia, white blood cell disorders, PNH, immune-mediated anemias, and thrombocytopenia, thrombosis, and hemostasis. Thank you so much, Dr. Weitz, for joining us today.
Sure, my pleasure. Welcome, everybody. And I actually got promoted, so I have to change that slide.
Awesome. Congratulations.
It's been a while, but nevertheless, I'm going to talk about PNH today. And I can't see you guys, so I can't tell how many people have heard me speak before and how many are completely new to this disease. So my apologies if I'm repeating myself. And for those of you who have never heard this, I hope you'll learn something. So the objectives for today are to try and answer some of the more frequently asked questions about the cause of PNH, the clinical presentation, how to diagnose it, the complications of PNH, and what the new treatments are. So we'll start with the very first presentation and first description, and that was by Sir William Gull in 1861. And he described this young man, 33 years old, who developed intermittent, he called it hematuria, which we now know as hematuria. And you could see that he had little blips, and sometimes, most of the time, his urine was kind of amber, but occasionally it'd be as dark as ink and indigo. And here you could see he got an infection. And when he got an infection, he had these episodes, more frequent episodes of hematuria. We know now that hematuria and hemoglobinuria are just symptoms of the disease, but it's really a pan blood cell disorder. This is a true stem cell disorder. It affects all of the cells in the bone marrow, including the white cells, the red cells, the platelets, even the lymphocytes and the monocytes. It's very rare. We know there are only about 10,000 patients in the US and Europe, and it is seen around the world, but there are no ethnic predispositions for the disease or preferences in the disorder. It may present early in life, although the vast majority of patients present in their late 20s, early 30s. And the manifestations may be classical, meaning that you have an evidence of hemolysis, red cell destruction, and hemoglobinuria with anemia. What's the problem in PNH? Well, we know now that it's due to a mutation in a gene in the blood stem cell. And that gene is called the PIGA gene. If phosphatidylinositol-glycan complementation class A gene, which is located on the active X chromosome. And that's important because, as you know, in women, or maybe you don't know, in women, because we have two X's, one is inactivated around the time of birth. So we have an active X. So anything that's on the active X will be expressed. Okay. So the mutation in this case is on the active X chromosome. And so it's acquired. You're not born with it. And why we get this mutation is unclear. There are bands of PNH in northern China, in the oil belt in Texas, where there may be some environmental exposure that leads to this mutation. So what's the significance of having that mutation? Well, that gene codes for the very beginning of what we call the glycosylphosphatidyl or GPI anchors, which are like little hooks that hook proteins to the cell membrane. And if you have a mutation in that anchor, then you don't make the protein. For those of you who don't know what a mutation is, it's basically a mistake or a copying error, which are very common in individuals. Most of them are insignificant, but when it makes a difference in the amount of protein that's produced, or it alters the protein, like in sickle cell, for example, or you don't make the protein, such as in hemophilia, then you may get significant disease. So here you can see normal clones at the top, okay, affecting all the blood cells. And here's an abnormal clone with this little star, and you can see that you start to affect the population of cells, and they're all affected by the mutation. Now, PNH patients are mosaics. So you have some normal cells and you have some abnormal cells. And here you can see, just showing you, a normal PIG-A gene will make the anchor. And here, because it has a mutation now, it won't make the anchor, or it only make part of the anchor, or a reduced amount of the anchor. And here you can see PIG-A it affects the very beginning of the synthesis of the anchor. And when you don't make the anchor, there's nothing to attach the complement proteins to, the CD59 or CD55 to. So we classified cells that are PNH cells as type 2 cells, which have a mild reduction in the anchor, or type 3 cells that have a severely reduced amount of anchor. And the anchor hooks, in particular, CD59 and CD55, which block specific complement proteins from damaging the cells. So normal people can have these PIG-A mutated genes. The problem is that it's a very tiny percentage, less than 0.001%. In PNH, these abnormal cells seem to have a growth advantage, and they become the predominant form of the predominant cell that we see in the bone marrow. And this may be a result of a change in the immune system, so that the bone marrow is no longer functioning properly, and these cells have an advantage. We know that there's a very strong association with aplastic anemia, which is an immune-mediated disease, which results in damage to the bone marrow. And we know that many PNH patients do have evidence that the bone marrow isn't working quite normally. So where does complement fit into all of that? Well, complement's a very complex system that is part of our innate or sort of primitive protective immunity. And it prevents viruses and bacteria and damaged cells from contributing to further cellular damage. It induces an inflammatory response, and it recruits inflammatory cells into an area that may be damaged, and it helps trap and digest pathogens or damaged cells. Normally, this is it's a very non-specific system, but there are very specific regulators that we have that bacteria and viruses, for example, don't have. So we can clear out those pathogens and not damage our own cells. The problem is when these regulators are abnormal or reduced. And in the case of PNH, the regulatory proteins are CD59 and CD55. And it's required for those to bind to those little hooks, those GPI anchors. So as a consequence of that, the blood cells are destroyed by excess complement activation, right? So normally complement circulates in an inactive form. It activates spontaneously or in response to infection, trauma, vaccinations, surgery, the presence of immune complexes, or autoimmune disease, for example. And it's regulated, again, the most important are CD59 and CD55 as cell-bound regulators of complement. So here you can see this is the CD59, and it blocks the insertion of the terminal complement protein, which is C9. Okay, so it blocks the insertion of another C9 molecule. If it's missing, then you end up with a micelle of C9, and that'll punch a hole in the membrane. That's one of the functions of complement. And so as a consequence, if this is your red blood cell, then you punch a hole in the red blood cell, and the hemoglobin, the red protein that carries around oxygen, will leak out, water will go in, the cell will explode and die. So the presence of CD59 is very important. CD55 works earlier, and it regulates the amount of active C3b that's bound to the membrane of the cells. Now, this punching of the holes occurs in the platelets, occurs in the white cells, etc. It occurs in all of the proteins, all of the cells, rather, that are affected by the loss of the GPI anchor in PNH. And here you can see this is a red cell membrane. This is an electron micrograph. And you can see all these holes. These are micelles of C9. So you could see that the membrane of a red cell is riddled with these holes, and there's no way the cell has enough extra membrane to reseal itself. This is an endothelial cell, and endothelial cells line your blood vessels, and they're supposed to be very smooth so things don't stick to it. And you could see all this blebbing and vesiculation of the endothelial cells, which should not be present. So we've already talked about this, that just the complement attacks the blood cells, you get destruction, which causes anemia. You also get the white cells damaged, and they release their granule content, and they activate other proteins called cytokines that then stimulate the production of things like tissue factor. And tissue factor expression on the monocyte is very important, and on the endothelial cell, very important in the generation of clotting, of blood clots, and the platelets as well. The membrane sort of vesiculates or blisters. So the red cell is the best way to illustrate the disease. And here you can see a normal red cell with its normal GPI anchors and its normal inhibitors. And then you activate complement, and nothing happens to this red cell. Here you can see that when there's complement activation on a PNH cell, the PNH cell lacks the anchors, lacks the protective inhibitors, and is then damaged. Okay. So what are the clinical manifestations of this disease? Well, there can be vascular manifestations such as arterial constriction, particularly in the pulmonary artery, but also you may see systemic hypertension, venous and arterial blood clots. As I mentioned, the pulmonary artery pressures may increase, spasm of the esophagus due to nitric oxide consumption when there's free hemoglobin in the plasma. It sucks up it binds to the nitric oxide and removes it. And that nitric oxide is a very important regulator of vascular tone and smooth muscle tone. So spasm of the esophagus, you may get abdominal pain, which may be a marker of microvascular thrombosis. In men, erectile dysfunction is very common. And other symptoms, in particular fatigue, very common. And the platelets are more reactive as well, which contributes to the thrombogenicity of the disease. The white cells release their contents, inducing inflammation. The monocytes express tissue factor, and which leads to blood clots, and the platelets become activated. And there is a receptor on the platelet called C5a that binds complement protein 5a, and that activates the platelets and induces them to form clumps and allows them to bind to the monocytes and vesiculate as well. Now, the hemolytic anemia part can contribute to renal damage, kidney damage. Most patients have anemia in PNH, although it does vary. I have patients whose hemoglobins are 12 and 13. When we treated them, their hemoglobins rose to 15. But most patients have a more significant anemia. And most patients have some component of bone marrow dysfunction. It may be minimal, or it may be really significant with profound aplasia. And thrombosis occurs clinically in about over 40% of Caucasian patients and about 20% of Asian patients. But they probably have, all of the patients with PNH are at much higher risk for thrombosis. You could see there's a lot of overlap with bone marrow failure syndrome. So here's PNH, and you could see it overlaps with MDS and aplastic anemia. I even had a patient who had a myeloproliferative disorder with a JAK2 mutation, and had PNH as well. And I've also had a patient who developed acute leukemia in his PNH clone. So there's a lot of overlap with these bone marrow failure syndromes. Why does the PNH clone expand? We really don't know, but we do know that there is an immunologic attack on the bone marrow. And once that attack is PNH cells may escape immune surveillance because one of the immune markers on cells is GPI linked. And so the immune attack may not attack the PNH cells. And then when the bone marrow recovers, it just recovers with more PNH cells. What that balance is, what determines that balance, we don't know. And thrombosis, as I mentioned, we now know it's less likely due to hemolysis, but more likely due to the complement activation affecting activation of all of the blood cells, generating tissue factor, and the effect of cytokines that are released from the complement activation, generating thrombin, which is the main enzyme inducing thrombosis. So how do we make the diagnosis of PNH? Well, in the old days, we used to do a test called the sucrose hemolysis test, which was the screening test to do the HAMS test. The HAMS test is an all-day event looking at the response of the cells to complement with complement activation, complement inhibition. It's very time consuming. It's not compatible with modern laboratory, so nobody's doing it anymore. The gold standard, which is infinitely more accurate, is flow cytometry on peripheral blood, not on bone marrow, on peripheral blood. And they should look at red cells and white cells, granulocytes or monocytes or both. And they look for the presence or absence of the GPI anchored proteins, CD59 or CD55. The PNH clone are the cells that are missing the GPI anchored proteins. So before we had complement inhibition, treatment was basically supportive, which really was unsatisfactory, with the exception of allogeneic bone marrow transplant, where there may have been limited eligibility for the lack of a matched donor. Steroids and androgens, erythropoietin, folic acid and iron, anticoagulation, all of these were in general less than satisfactory. So about coming up on almost 20 years, not quite, we've had complement inhibition, which has revolutionized and really changed the lives of so many PNH patients. There are 2 approved complement inhibitors, but there are many in trial or going into trial. So eculizumab and its newer version, which is ravulizumab, which is the longer acting version, are both approved for PNH. And they are monoclonal antibodies, highly humanized proteins that block complement protein 5. The ravulizumab has a modification that allows it to be recycled back into the circulation so that the half-life is 51 days compared to eculizumab, where the half-life is 10 days. So obviously you can give this drug at much longer intervals, and we give it every 8 weeks. We know that these drugs quickly and really remarkably reduce hemolysis. They stop the hemoglobinuria, they increase the hemoglobin levels, they reduce the thromboembolic complications and all of the other complications associated with PNH. So this is just to show you how, and my apologies for not changing the names, how eculizumab works, and it blocks C5 so that complement activation of the terminal complement that punches the hole in the membrane is reduced or eliminated. So if we look at LDH as a measure of intravascular hemolysis, it's a very good measure of intravascular hemolysis. You can see that in there were 3 studies which led to the approval of eculizumab. The Triumph, which was placebo-controlled, randomized, and blinded. So theoretically, nobody knew who was getting what drug. Okay, so here you can see the placebo patients, and they had to tough it out for 26 weeks, and you could see there's no change in the LDH. If you look at the patients who were getting eculizumab or Soliris, you could see within the first week, the LDH drops, and by 4 weeks, it's normal, and it bounces around a little bit, but pretty much stays at this very low level. The Shepherd trial was an open label 52-week study that looked at safety. And again, superimposable on the Triumph Soliris data. very rapid reduction in the LDH. And once it's down, once the LDH is down, it stays down. Okay. The AAGIS study is the Japanese study. And as you know, all studies have to be repeated in Japan because it has a very different patient population. And here you can see the AAGIS study. And again, superimposable. It's really remarkable. All three studies, I should say, demonstrated that the drug effect was highly reproducible and very effective. And there, when the TRIUMPH patients on the placebo arm go on to the extension trial and they get drug, again, all four arms are superimposable. All right, so here's one of the first patients, and they, you could see the hemoglobinuria, and after they got ECU, it was, the urine was clear. We know that the ability to maintain a good hemoglobin was markedly improved in the eculizumab arm with a p-value that's highly, highly statistically significant. We know that transfusion requirements drop significantly. Not every patient becomes transfusion independent, but the vast majority were. And as you can see, again, highly statistically significant p-value. So it stops the fatigue. It stops the abdominal and esophageal spasm. It improves the erectile dysfunction. It improves the sense of well-being, and it reduces the need for transfusion. And it does appear to reduce thrombosis. So if you look at the fatigue, in the TRIUMPH study, as I mentioned, nobody knew who was on which arm. This was a blinded, randomized trial. And all the patients could receive transfusion to a hemoglobin of 10. So here you can see the placebo group. Nobody had an improvement, significant improvement in their hemoglobin and in their fatigue scores, rather. So here's the fatigue score for these were in the placebo group. And you could see the hemoglobin levels hang at about 10. But in the treatment group, those patients who received the eculizumab, within the first week, their fatigue scores improved. And by 4 weeks, they were over 3, which is the benchmark. And once they're up, they stay up and they never look back. And the hemoglobins, again, hovering around 10. So it's not the degree of anemia, it's due to the complement activation. And we looked at that, and it's really cytokine driven, and it's inflammatory in nature as well. If you look at the thromboembolic event rate, you could see a marked reduction. And this could not be by chance. Granted, it wasn't a primary outcome of the study, but nevertheless, a marked improvement in thromboembolic reduction. When we looked at D-dimers, there's a significant reduction, and that's a very good clinical marker of hemostatic or blood system clotting activation. It improved kidney function, it reduces thrombosis, and it may also improve hypertension, reduces pulmonary hypertension as well. But more importantly, what does it do for overall survival? And here you can see the historic data, and here is the newer data with patients treated with eculizumab, and this is from the UK system, and you can see that it's really normalized. This is compared to age-matched controls. So significant improvement in overall survival, coupled with significant improvement in overall quality of life, et cetera. What about pregnancy and PNH? As I said, this affects people who are in their 20s and 30s, and they may want to have children. We know that pre-eculizumab, there was a significant increase in fetal loss, increase in the risk of thrombosis, and an increase requirement for transfusions. Originally, eculizumab was deemed category C, but that categorization has been removed. It is safe in pregnancy. There are no abnormal fetal outcomes with fetal abnormalities. It reduces fetal loss. It reduces the maternal morbidity and reduces the risk of thrombosis, although we still recommend anticoagulation. Now, there's always a downside to treatment, and the biggest downside to treatment is the risk of meningococcal infection. Meningococci or Neisseria bacteria of any form are the only form of bacteria that requires terminal complement. And remember, eculizumab and ravulizumab block C5, so it blocks terminal complement generation. So all of the patients are at risk for Neisseria infections. That includes gonorrhea and especially meningococcemia, meningococcal infection. So patients must be vaccinated. We have the recommendations, initial recommendations were 2 weeks prior to treatment, but we have seen some thromboembolic events as a consequence of vaccination because it increases your complement activity. So we recommend getting the complement inhibitor into the patient and then vaccinating. So you don't have to wait the 2 weeks. We strongly recommend giving the dose of Ecu or Ravu, vaccinating even that afternoon, and then covering with antibiotics for at least 2 weeks. Many of us recommend penicillin prophylaxis if patients can tolerate it. But that's really an individual choice. The FDA did not mandate that. We do want patients to be aware, and we want their caregivers to be aware that they are at risk for this unusual infection. And you all have a little card that describes what to look for. And don't be embarrassed if you have a fever, if you have a stiff neck. Don't hesitate to call your physician or go straight to the emergency room. We do recommend having a bottle of Cipro at home, 750 milligrams, which you could start taking, but you need to get to the hospital right away. There is a headache associated with Ecu and Ravu. For the first, it doesn't usually even last the whole first week, but it may last. You may have it the first week or with the second dose. It is very expensive, although there are certainly ways to take care of this. And there are programs that can help cover some of the costs, especially the co-pays. It's inconvenient because it's intravenous. Certainly with Ravu now, it's every 8 weeks, which is a lot less inconvenient than Ecu, which was every 2 weeks. There are some studies looking at whether it can be given subcutaneously, et cetera, but those have not been reported yet. So if you've gotten treatment for PNH, how do we know that you've responded? Well, we've said, this is really Antonio Risitano's data, and he's looked at how to classify these patients with PNH who are getting anti-complement therapy. And you can see that a complete response, you have a hemoglobin over 12, the LDH is less than 1.5 times normal, and the absolute reticulocyte count is low. Major responses, hemoglobin's greater than 12, the LDH may pop up a little bit, or the reticulocyte count may be over 150,000. And we'll talk about this in a minute. A good response, hemoglobin between 10 and 12. Some patients will have some increase in LDH, most will not. Partial response, hemoglobin's between 8 and 10, and you want to rule out extravascular hemolysis or a poor bone marrow response. Minor response, hemoglobins of less than 8, and again, they may need transfusions every few months, again, the hemoglobins may be less than 10. If they have no response and they still have still profoundly anemic, and if they have no response, then you should probably look for the Japanese mutation in C5. It's been described in a handful of patients. I think there are 13 cases described, one in Argentina, but the vast majority are in Japan. And they have a polymorphism in the C5 molecule that right where ECU binds. And so it's not allowing the drug to bind. And in that case, you need a different drug. All right, so when's ECU less effective? I already told you about the C5 mutation, but it's very rare. The patient doesn't have PNH, and sometimes that is true. Or the clones are very tiny, and it's really primarily bone marrow failure, and the patients really should be treated as aplastic anemia. The other issues are, one, if there's evidence of breakthrough hemolysis. So you get a response, and then at day 10 or 12, or right before the next dose of ECU, or right before your next dose of RAVU, you have dark urine, or you have evidence of hemolysis again. So you're breaking through. And that can be due to inadequate dosing, much less common with RAVU than it is with eculizumab, or there's increased complement activation. So we've had a couple of patients who got their COVID vaccines and had a little blip in hemoglobinuria due to the increased complement activation. Or you get an infection that will increase your complement activation. Or heaven forbid, you get COVID, okay, which will definitely increase your complement activation and cause you to have evidence of hemoglobinuria. Or there's extravascular hemolysis. So it's not true breakthrough in the classic sense that you're inadequately dosed, but more likely that you're having increased clearance because you're blocking at C5, so you're accumulating C3b on the cells. So this is from Antonio Brisitano's paper, and you can see that here are patients who have ongoing intravascular hemolysis, but here you could see all these patients have a lot of C3b on their cells, so the cells are being cleared in the liver and the spleen. And again, ECU has a short half-life. We don't see that with RAVU very much. Although I do have a few patients who get their drug a little early. They get their drug at 7 weeks instead of 8 weeks. We can look in these patients, the LDH is always normal in between. So at day 8, the LDH is normal. On day 15, it'll pop up again. And that's telling you that there's increased hemolysis. We check the CH50, the level of the CH50 will pop up again as well. So you can either increase the frequency of the dose to every 12 days, or you can give an extra dose, or you can increase to 1,200 milligrams every 14 days. So, but we know with ravulizumab, this is less likely to be a problem. And again, it's due to the accumulation of C3b on the cells. Some of this has to do with a polymorphism in another complement receptor known as complement receptor 1, and that modulates C3b deposition on the red blood cell, and on the cells, I should say. So low expressors have increased C3 on the membrane, and they're 7 times more likely to require a transfusion. So what do we do about this? More likely transfusions. Splenectomy is not the greatest answer for these patients, and prednisone really does not work. So we've already talked about RAVU. What's new in the field? I know you're all eagerly awaiting this. So RAVU is approved, and again, that's the extended life. There are some biosimilars that are in trial, C5 inhibitors that are sub-Q weekly. C3 inhibitor, pegcetacoplan, or APL2, completed phase 3 trial. We're waiting to see whether it'll get approved. There is an expanded access program available, so you could talk to your doctor about that. And then there are alternative pathway inhibitors, factor D and factor B inhibitors, that are going into trial. Factor B, this is a Novartis drug, and it's entering phase 3 trial now. Factor D, also entering phase 3 trials, and there are 2 drugs. One is danocopan, and the other is BCX099. And those are all in trial right now, or they're going into trial. A compstatin-like molecule that blocks, again, blocks C3 is in trial. And then there's a small molecule C5 receptor blocker that also is going into trial. So there's a lot of activity and a lot of interest. The cool thing about D and B, and these are oral drugs. So the pegcetacoplan is sub-Q, done with a little pump, but these are oral drugs, so it'll be very interesting to see. Right now, they're overlap. We'll see how they do as on their own. So this is from the Pegasus study. This is the pegcetacoplan, and you can see that there was a run-in period where they overlapped with eculizumab, and here you can see the patients who got the pegcetacoplan, and again, their hemoglobins were almost 4 points higher than the placebo group who were getting, or I shouldn't say placebo, the patients who were getting just eculizumab. And here you can see the LDH, again, on the pegcetacoplan, much lower than the study group. The reticulocyte counts were lower. The FACIT fatigue was improved, and the indirect bilirubin dropped, all showing how hemolysis was reduced. This is from the danocopan initial trial, and this was a 24-week study of ECU monotherapy versus danocopan plus ECU, and you could see at 24 weeks a 3-gram improvement in hemoglobin, reduction in retics, reduction in bilirubin, improvement in the LDH, and marked improvement again in the fatigue scores above the improvement with eculizumab. And this is the Novartis drug LNP023. And again, you could see it's as effective as factor D. This is a factor B inhibitor. And here you could see it reduces the C3 degradation products, blocks C3 deposition, equally effective, is not even more effective in blocking hemolysis than the factor D. And factor D is a cofactor for factor B, which the LNP023 blocks. And again, you could see it appears to be very effective as well, and perhaps even better than the anti-C5. So it'll be very interesting to see where these drugs shake out, and we'll keep you posted on those. I do want to say a word about the global PNH registry that we have. It's a data collection study. It's not a drug company study. And the goals are to collect data on demographics, quality of life, the types of treatments, the diagnoses associated, and the symptoms of PNH. And it's really patient-driven. And we hope that it'll give us a sense of where we need to look and what we need to do to improve the management of PNH patients in the future. And the key features are, it's an electronic survey about your experience. Patients or caregivers or guardians can enter information. It's on the web. It's all easy for you to do. It's anonymous and it's stored securely. So who you are is not going to be revealed to anybody. Patients will have access to the collected data, and there'll be periodic updates. It'll be ongoing with new surveys added. And again, they may share the de-identified data with individuals or institutions who are doing research or clinical trials, if it's approved by the advisory committee. So we'd love for all of you to participate. It would really enhance the registry. And this is really going to be an international registry. And I'll stop there and I'll be happy to take any questions.
Thank you so much, Dr. Weitz. We do have a few questions for
Sure.
you. Our first question says, can you address PNH as a secondary disease to aplastic anemia?
Well, they kind of coexist. So it's not so much a secondary, they coexist. So you may have a tiny PNH clone when you have aplastic anemia. And then when you're treated for aplastic anemia, your disease, as your bone marrow recovers, you may recover primarily with PNH cells, which may then give you clinical PNH down the line. The converse is true as well. We've had a couple of patients with clinically active PNH, with hemolytic PNH, who, for one reason or another, over time develop bone marrow failure. That too can be seen. Less common than the other way around, but definitely can be seen. We know from Dr. Sugimori's data that about when the bone in aplastic anemia, about a quarter of the patients will lose their PNH clone when the bone marrow recovers. So you recover with normal cells, unaffected cells. But that means that 75% of patients will continue to have a PNH clone. And of those, 30% are going to expand the clone and develop clinical PNH. Does that answer your question?
Yes, thank you.
Okay, sure.
When you have secondary PNH to aplastic anemia, when do you consider treating the PNH?
Only if the patient has evidence of classical or hemolytic disease. If the clone is, the argument is, should you treat if the clone is over 10%? If the patient's asymptomatic and doesn't have evidence of hemolysis? Probably not. So we're looking for an increase in the LDH over 1.5 times the upper limit of normal, or evidence of hemolytic disease or thrombotic disease.
Thank you, Dr. Weitz. If you have a transplant for aplastic anemia and you do have, it is known that you have a PNH clone, does the transplant also cure the PNH?
Yeah, it does. For most patients, there's some description of a rare patient or two in whom the PNH clone came back. But in general, yes, it is curative. And the
Thank,
PNH goes away.
thank you. Our next question is, when you refer to transfusions, is that only red blood or also platelets?
Well, primarily red blood cells. It is rare, but it does happen that you'll see the platelet count of less than 10,000. That's usually in an aplastic patient, and those patients do need red cells and platelets transfusions.
Thank you. Would you treat PNH when clone is less than 50%?
No, that's a tough one. We do have some patients who are treated with clone sizes less than 50%. Most of those patients, the clone is expanding. So they went from 10%, now they're 20%, now they're 30%, or they're 49%. So yeah, we do treat patients that are in that middle group. It just depends on the clinical circumstances.
Okay,
There aren't any
thank,
rules for this.
thank you. Is it safe for a PNH patient with moderate aplastic anemia to use Promacta?
Yes, yes, and I have many patients who have used either, they've gotten full treatment for aplastic anemia or just Promacta. So full treatment being ATG, anti-thymocyte globulin, or rapid anti-thymocyte globulin, cyclosporin or tacrolimus, and L-Trombopag or Promacta. Yes, it is safe. In some ways, it's maybe even safer. I don't know. But yes, it's not a problem.
Thank you. Are you aware of any studies being done on fatigue and brain fog associated with PNH and or how to prevent these serious side effects?
Um, yeah, well, we have data that suggests that this is cytokine mediated. So all of the new clinical studies are looking at those cytokine profiles. And the vast majority of patients with treatment get better. There are some who do not. I'm not quite sure why they're not better, but the vast majority do show improvement. And when you look at the quality of life scores, they are just dramatically better and than they were without treatment. And some of the newer treatments, as I mentioned also, for example, the pegcetacoplan, you could see that the fatigue scores improved above and beyond, 10 points above and beyond what the FASIC fatigue showed just with eculizumab.
Thank you. If a patient does not want to use either Soliris or Ultomiris, what then? Can a patient just be on a blood thinner and discuss bone marrow transplant?
Um, sure, you don't have to take any treatment. Um, but two things. As I said, bone marrow transplant is curative, but you need a match, or you have to do a haplo with all of the complications of haplotype, and the Cytoxan and all of that. But yes, you can do. We have done some haplos. It's still probably better to do a full match, and that may be preferably a sibling match, but you can also do a matched unrelated donor. The problem with doing nothing is the risk of thrombosis. And even on an anticoagulant, you still are at risk for thromboembolic complications and also for VOD, vaso-occlusive disease during the transplant. So I think you can start out if you don't want to take the ECU or the RAVU, that's fine, but they need to act quickly then.
Thank you. If there are no symptoms, only being a little tired with the PNH clone lower than 50, would you still consider treating with Soliris?
Well, it also depends on what the other parameters look like, what the hemoglobin is, what the LDH is, what the D dimers look like. So there are a lot of things that go into making that decision. We would probably recommend using RAVU rather than ECU at this point in time, since it's non-inferior to eculizumab. And it does limit the number of breakthroughs that patients have, and it's much more convenient. And in fact, it's more cost effective over not for each dose, but over the course of the year. It's not quite as expensive as eculizumab is.
Thank you. And this question is regarding a patient that has not had a good response to one of the C5 inhibitors. They're still transfusion dependent. Once the C3 inhibitor, if it becomes approved, how would they go about switching, and would it be potentially recommended to switch to see if that would not provide a better response for a patient?
Yeah, so what they would do is there's an overlap period, okay? And remember, the pegcetacoplan trial was done only with eculizumab. It wasn't done with RAVU. So it's going to take a little maneuvering to figure out what to do with the RAVU. The reason is that RAVU has a very long half-life. So, but there will be an overlap period, just like with the clinical trial. And then you just stop the ECU and let the patient fly just on the pegcetacoplan.
Thank you. And for patients who are considering or have not yet, but are thinking about switching from Soliris to Ultomiris, what is that process like?
So when the patients do, it's very simple. When the patients due for the next dose, okay, of ECU, we just substitute the RAVU with the Ultomiris. And then they get their first loading dose when they would have gotten their next ECU. And then they get another dose 2 weeks later. Then they go on to every 8 weeks. Very simple.
Have there been any known side effects from the switching that patients should be aware of?
Some people complain of headache and that the headache seems worse. I think that's probably one, it's a bigger protein load. So that might be it. Might be causing the headache. But two, some of these patients may have some breakthrough. And so again, you get this rebound nitric oxide enhancement that can cause a migraine-like headache. But there's no real difference in side effects from ECU or RAVU. They're all the same.
Well, thank you. And we have some questions about the registry. Our question is, how is the new registry different from the Alexion registry?
Well, one, it's not owned by Alexion. It's not run by Alexion. Okay. So it's run by a group of physicians, many of us who have experience with PNH, and it's more focused on patient outcomes and things like that.
Thank you. If a patient has MDS, aplastic anemia, and PNH, and is transfusion dependent, how do you know which one of these diseases is causing the low counts?
Okay, so they have MDS, hypoplastic MDS. Is that what you're saying?
They have MDS, and aplastic anemia
Right. So
and
hypoplastic
PNH.
MDS versus PNH. So it also depends on the size of the PNH clone. Okay. Again, if it's primarily aplasia, you treat the aplasia. Now, that may be that depends on whether or not the MDS, how they're describing the MDS. If the MDS is documented with cytogenetic abnormalities, that's true MDS. If it's just that it looks funky under the microscope, MDS, that's not MDS. So you really have to define it by the presence or absence of significant mutations. So what we would do would be to send off a mutation analysis. It's a profile, an MDS profile, to see whether there are TET mutations or RUNX mutations, things like that, that are high risk for developing down the road true MDS or AML. Because those patients probably, while you can transiently treat them with ECU, they're going to progress. The MDS is going to progress, or the leukemia is going to develop. You're going to want to transplant those patients if possible.
Thank you. If a patient is being treated for ITP, but the low platelets have to do with PNH, should the ITP treatment be stopped because platelets not increasing?
Yeah. It's funny because I have a patient who presented just that way. They treated her for ITP. She didn't get better. They did some bloods, and the LDH was a little elevated, although not major league. And they did a PNH clone, and it was about 11%. She actually participated in a clinical trial we had. It was a single dose finding trial, single dose of a different complement inhibitor. And we have done nothing but watch her. And over the last almost, let me see, how many years now? 7, 8 years, her platelets have gone up spontaneously. Her PNH clone has gone down and is less than 0.01 now. So I mean, yes, I would not treat with ECU or RAVU or even PEG. I would just watch and see what happens.
Thank you. For patients who have been treated with the Soliris or Ultomiris, and they end up having to go to transplant, does using drug therapy affect the effectiveness of transplant? And does it increase the risk of graft versus host disease?
No, if anything, it'll probably lower the graft versus host, which does have complement activation. But remember, RAVU, I mean, it's going to be 51 days out that they're going to, you probably just need one dose before. What we did with ECU is we gave a dose before, we gave a dose 2 weeks later, and then when you document that the transplant has taken hold, you stop it. So it does not affect the effectiveness of the transplant. Whether or not it has an effect on the GVH, we suspect it might, but I can't tell you that. Is it safe? Yes.
Thank you. If a patient has a DMMT3A mutation, should a patient consider Soliris or a bone marrow transplant first?
Well, that's a leukemia mutation. That's a pre-leukemic mutation. So it depends on what percentage of the cells have that mutation.
Okay, thank you. And we had a couple of questions that were about the registry. Another one. There will be information. It asked, how do I fill out the registry? So as I'll answer that, Dr. Weiss. As Dr. Weiss said, that information will be forthcoming. That information will be coming from the foundation. So be on a lookout to get emails from us about that, or you're welcome to email the foundation. You can use our help account at help@aamds.org, and we're happy to answer any of those questions for you, and make sure that you're on our email list to get that information that will be coming forth soon. So any of those questions we're happy to answer. There was another question, will this presentation be recorded? Absolutely, it's being recorded, and you will have access to that presentation shortly here on the platform. And Dr. Weitz's slides will be part of the presentation. Dr. Weitz, the question is, are there any upcoming treatments for PNH that you are most excited about?
Well, yeah, I'm very excited about the factor B and factor D. I mean, I think these are very novel. We already have at least preliminary data on the danicopan, but I know they're working on a more concentrated dose. The BCX 0999 is very exciting. It's been used in South Africa where they don't have access to ECU for the most part. Very, very promising results. And again, oral, twice a day dosing. Yeah. So I think those are going to be very exciting. And again, I mean, you know, the data with the pegcetacoplan looks very good in the right patient.
Great. Thank you so much.
Sure.
Well, thank you so much, Dr. Weitz, for sharing your
welcome.
time and your expertise with all of us. And if you'd like to watch this session again at a later time, it will be available on the conference platform within just a few days. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to our help account, which is help@aamds.org. Call our helpline at 800-747-2820, extension 2, or you can submit your question on our Facebook page. Please be sure to visit our exhibit hall. And our next educational sessions will start in approximately 15 to 20 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are always here to support you and your family, as we have done for the past 37 years. This concludes our program. Thank you again, Dr. Weitz.
Oh,